Okay, for this section, we're going to be talking about obstructive defects of the heart. And the three we're going to be talking about in this category are coarctation of the aorta, aortic stenosis, and hypoplastic left heart. Coarctation of the aorta is when there's a narrowing in the or an obstruction in the descending aorta. Aortic stenosis is when there is a narrowing of the aortic valve. And hypoplastic left heart is one of the most severe heart defects. It is the largest contributor to infant death, and its absence or stenosis of the mitra and the aortic valves. The signs and symptoms are going to be a murmur, CHF, cardiomegaly, possible cyanosis, diminished pulses, and poor perfusion. In coarctation of the aorta, like I said, it is a narrowing of the aorta. The body has to actually develop a collateral circulation to survive, or have a patent ductus arteriosus, or PDA. So you remember when we were talking earlier about the in the first session we were talking about cardiac defects that happen because the PDA remains open and it doesn't close. And so there's a medicine that we can give it to close the PDA, the Indocin. However, with obstructive heart defects that we're going to be talking about in this section, we want that PDA to stay open. So there is a medication that can be given to maintain the patency of the PDA, or to keep it open, and that's going to be your prostaglandin E. It does maintain patency of the ductus arteriosus. The symptoms of coarctation of the aorta is going to be a disparity in the pulses and the blood pressure. This can be seen in a newborn, and we talk about how important it is to do a good assessment, and one of the assessments we do in a newborn is check all the pulses. So if we notice that the pulses in the arms are bounding, and we notice that the pulses in the feet are faint or weak, that would be a disparity in the pulses, and that would be something that we would definitely want to document and let the doctor know about. And one of the first things he's going to want you to do is verify this perfusion to these extremities by doing a blood pressure in all four extremities. He's going to want to know. He's going to want to know that that there is a discrepancy in the blood pressures also. Other symptoms include congestive heart failure, acidosis. Older children would complain of dizziness and headache, and maybe fainting, and maybe nosebleeds, and they may have a heaving precordium. As far as the management goes, we talked about prostaglandin E, and that is something we would definitely want to give to these children. It may be that they can do balloon angioplasty and insert a stent to keep that open, or to maybe open it up a little bit more. That's really initially there just to help, because sometimes it might recur. So these patients definitely require lifelong follow-up. And I did want to say, as far as the prostaglandin E, what we're giving to keep this PDA open, it can keep it open if it hasn't closed, but if it started to close, it can actually reopen it a little. So it does help to to give that as soon as possible, and it does promote blood flow to the lower extremities. There are times, though, that the balloon angioplasty, like I say, that is like palliative, is just there until maybe the child gets old enough that they can do surgery. The surgery would require a resection of the coarctation, so they would essentially just cut the narrowing out and resect the two healthy ends so that there would be no decreased blood flow. There are times when collateral veins might actually develop as the child gets older, and your book talks about how they do have these collateral veins in place by the age of 10. So that seems like it takes a long time for that to happen. It could happen earlier, but usually by age 10 they do have collateral veins. Your book talks about rib notching, and that may be seen in children 10 years of age and over. It's just a smooth contour of the ribs that's changed due to the collateral vessels. So when you're looking at collateral vessels and you see rib notching, you'll know that it's associated. Older children may complain of weakness or pain from this. Their heart sounds, you'll hear S2. The S2 is loud and it's single in this heart defect. So it's important to know that you would definitely see blood pressure higher in either the upper or the lower body, and so you definitely need to know which one that is for coarctation of the aorta. You'd want to know that there is a discrepancy. And this is a picture of it. You can see the little kinking of it right there, or the narrowing there. The next one we're going to talk about is aortic stenosis. And like I said earlier, that's a narrowing of the aortic valve. There's three types. There's the valvular, the subvalvular, and the supravalvular. And what happens is there's two valves rather than three. The obstruction tends to be progressive. In other words, the valve tends to narrow off more and more. The symptoms, they may be asymptomatic for a while. Decrease in blood pressure, increase in heart rate, poor feeding, dizzy, murmur, exercise intolerance, and they may experience chest pain. Cardiogenic shock and sudden death can occur with aortic stenosis. As far as exercise intolerance and the chest pain that's associated with that, sometimes they may do exercise testing, and that helps to determine the amount of obstruction, and it does allow it, and it does also help them see what is an allowable exercise for the child without them having chest pain, or what is an allowable amount of time to do an exercise that's approved for this child. But it does help to know how far they can actually go before they become have these symptoms. The treatment is a valvotomy, which is an aortic valve replacement. In infancy, you might hear there may be some congestive heart failure with significant stenosis. You may hear a murmur, and you may hear an ejection click. Just know that anytime it has to do with a valve, it's not unusual that you will hear a click sound when you're listening to the heart sounds. And with aortic stenosis, you would definitely possibly hear this ejection click. The meds are prostaglandin E is given to newborns if it is detected at that time to maintain the PDA until the aortic valve can be dilated. They may do about valvuloplasty by catheterization, which is the balloon. As it progresses, though, during childhood, the valve becomes calcified, and that can actually lead to left ventricular failure. And they may actually have valve replacement. When they have valve replacement, there's a lifelong anticoagulation therapy that would go along with that. And also lifelong infective endocarditis prophylaxis would be required. And what that is a prophylaxis medication required prior to procedures such as surgery, of course, but also dental procedures or any kind of procedure that an infection might occur. You would want them to know that they need to take a prophylaxis prior to the procedure. But in some instances, it might be that they take it all the time. In other words, not just before procedures, but all the time. Chest pain, syncope, and sudden death, and that usually happens with vigorous exercise. And this is some examples of it. You can see the normal aortic valve with the 3 leaflets, and then you see the stenotic aortic valve, which is closed off more. So you can see that it's closed off more because it only has 2 valves. That does become stenosed, and over time it gets so bad that the valve has to be replaced. And you can see where it is positioned within the heart. The last one we're going to talk about with obstructive is hypoplastic left heart. And what that is underdevelopment of the left side with the absence of stenosis or stenosis of mitral and aortic valve. So either the valves are not there, or they are there and they're stenosed. They're not functional. There's severe congestive heart disease, a large contributor of infant deaths if no surgery by 3 days old. So this is something that you would be aware of pretty quickly, and the doctor would want to act on this real quickly. These babies are not going to survive unless something is done. You would like to have an atrial septal defect in these babies, and you might have other defects, but you would like for them to have another defect that is allowing blood flow. So atrial septal defect or a patent foramen ovale would allow blood to mix to the lungs and back according to the resistance. So that would be something that you would hope would be present also, because that would be helpful in this situation. The symptoms, however, are these babies are gray in color. They have trouble breathing, dyspnea, tachypnea, grunting. They're cool. Their extremities are poorly perfused. There's no oxygenation going to these extremities. You may hear a murmur and mild cyanosis. They may not be blue, but they're going to be gray. Their color is not going to be good. Their pulses are going to be weak. The treatment, like we said earlier, they'd have to have surgery by 3 days of age. So the surgical repair or transplant, and that's done. That's called a Norwood procedure. The surgery is called a Norwood procedure, and it has 3 stages of surgery. And your book talks about that, and so you need to look at that and be, kind of be a little bit familiar with how these babies would be able to survive. A transplant is something, a heart transplant is something that would be helpful. There's not very many newborn hearts that are available, so that's not something that's always an option. You would definitely be using the prostaglandin E in this situation, because you would definitely want to keep anything and everything open. So if it helps to keep any of the PDA or anything open, you would want to be giving prostaglandin E for that. It does lead to shock, metabolic acidosis, and death. 45% die before 5 years of age, and so very important to have the surgery. I believe in your book on page 840 is where it talks about this. So you might want to look at page 840 in your book. I think it talks about the Norwood procedure and the 3 stages. The first stage, it happens in the first week of life, like I said. The survival rate is low. Physical activity is limited. And there are other impairments too, and that's on page 826, I believe. Oh, on page 826, what I have on 826 is an evidence-based practice that I wanted you to look at. It's on 826, as far as neurodevelopmental outcomes in children with complex congenital heart disease based on heart defects. So I'd like for you to look at that. A lot of times O2 is given. O2, supplemental O2 is avoided. Obviously, it's not going to help because the blood's not going to be oxygenated. But however, because these children have such a severe defect, your book talks about this, I believe, that 50% of parents usually choose non-surgical comfort care only. In other words, a heart transplant would be hard to correct this because there's not that many hearts available in newborns. And surgical repair is like a stage surgery, the Norwood procedure, and babies may not be strong enough to survive. And when they are really kind of told by doctors that many babies don't survive this, some parents may choose comfort care only. So, and this is a picture of it. And there's a very small aorta. There's a vessel connecting the aorta and the pulmonary vessel artery. And you see that little bitty portion up there. Well, you can see the outline of how big the left atrial and the ventricle should be. But you see the red area, and you see that it's definitely very, very small. But that's how it looks. So that concludes the second part of this voiceover PowerPoint. And so I will be getting the third part to you in just a little bit. Thanks. Bye.